Good afternoon, friends. I will be talking about common cardiac toxins which we see in India in this presentation. So, I will be talking about calcium channel blockers, in small about beta blockers, and then about cardiac glycosides, including digoxin. So, calcium channel blockers are seen extremely rarely in India, or at least they are reported extremely rarely. In this epidemiological study of poisonings seen in India, the pharmaceutical poisoning, that is the drugs which are prescribed when they are used for poisoning, the percentage was only 10%. Most of the cases were due to pesticides, and out of this 10%, only 3 to 4% were due to calcium channel blockers. In India, the age group which is most commonly involved in calcium channel blocker poisoning were young adults, and mostly they were females, and mostly the poisoning was intentional, that is suicidal. However, around the world, children are importantly affected by calcium channel blockers, mostly due to accidental ingestion. The most common agent reported in India is amlodipine, which is also the most commonly prescribed calcium channel blocker. The mortality varies widely worldwide. From European studies, the mortality from CCB poisoning is reported to be around 2%, but it is only around 1% in US. Among the ICU patients, patients who need ICU admission, the mortality was up to 12% in a South African study. The data from India is very scarce. I couldn't find a study which systematically calculates the mortality associated with CCBs, but what I can find is mostly case reports, and generally, if the patient survives, the case report is published. So the percentage of mortality can't be determined in India. There are basically two classes of CCBs: the dihydropyridines and non-dihydropyridines. Dihydropyridines are drugs like nifedipine and amlodipine used for hypertension, and they are not cardioselective. Basically, they act on peripheral vasodilators to cause peripheral arterial vasodilatation. The dihydropyridines are drugs like verapamil or diltiazem, and they act on the heart to reduce the heart rate, mostly used in uh, atrial tachycardias. Some distinctive pharmacokinetics of these drugs are they are highly protein bound, lipid soluble, and eliminated by the liver with the enzyme CYP450. And certain drugs, if taken along with these drugs, like the macrolide antibiotics, can prolong their action. Also, they are available in extended or sustained release formats, where uh, the toxin effect can last for days. The most common drug, which was amlodipine, uh, which is implicated in poisoning in India, has a very long half-life of 30 to 50 hours, and its effects when taken in overdoses can last for several days to weeks. The clinical presentation, a CCB poisoning should be suspected in any patient who is already taking a CCB for his medical condition and now presents with hypotension, bradycardia, and hyperglycemia. Hyperglycemia is a known complication of CCB poisoning because the CCBs inhibit the calcium channels in the islet of pancreas and thus decrease the secretion of insulin, and thus there is hyperglycemia. In most poisoning we see hypoglycemia, but in CCB poisoning we see hyperglycemia. So if you see hypotension, bradycardia, hyperglycemia, you can suspect CCB poisoning in a patient. Besides, there can be other manifestations uh, which are generally secondary to shock, like ARDS, altered sensorium, coma, seizures, etc. Management, basically, first of all, you have to manage the airway, breathing, and circulation. Whenever the patient comes in hypotension, give fluids. Try to look for a echo if the ejection fraction is not too low, you can give good amount of fluids just as you give in any other type of shock. Start vasopressors early. In if the inotropy is low, you can use ADR. If the inotropy is good, the shock is mainly vasodilator, prefer noradrenaline. Try to avoid vasopressin and dopamine. Gastric decontamination can be tried within 1 hour with activated charcoal or gastric lavage. However, in some authors have suggested whole bowel irrigation by giving Peglec in case of sustained release tablet. However, the efficacy is not yet established and it should be done only if there are no contraindications like hemodynamic instability. Specific management of CCB poisonings can be divided into class 1 indications to class 2 and class 3 indications. The high dose insulin euglycemic therapy or HIET is the class 1 indicated and most recommended treatment. Also, some treatments like intravenous lipid emulsion or dialysis are not recommended by the AHA guidelines. Coming to atropine, you can try atropine 1 ampule every 5 minutes up to 3 ampules, and it might transiently increase the heart rate or it might act on its own in low doses of poisoning, but in severe poisoning it might not be effective. Similarly, temporary pacing can be tried, but the studies have shown that it is rarely effective, and therefore don't directly put a transvenous catheter. First try transcutaneous catheter. Now coming to high dose insulin therapy, which is the treatment of choice. Insulin increases the glucose uptake in a stressed heart and thus increases its inotropy. This is the main action behind HIET therapy. The dose which we have to give is very high. It starts with around 1 unit per kg IV, that is around 60 units per hour of insulin, which is at least 10 times of the dose we give in DKA, and it should be started immediately. If there is no response to fluids and vasopressors, it should be started immediately, and the response should be assessed every 15 to 20 minutes. If the response is not adequate, that is the BP is not rising, the shock is not resolving, you should double the dose every 15 to 20 minutes, and you can go up to 10 units per kg, which is a very high dose, up to 600 units per hour of insulin. Definitely this will cause hypoglycemia, and you have to infuse high doses of dextrose along with these high doses of insulin. You have to give very concentrated solution D50 and if available D70, and for this you will need a central line. You have to monitor the electrolytes very frequently and ABG very frequently, because such high doses of insulin will cause hypokalemia, hypomagnesemia and phosphatemia. So if you find a adequate response with high dose insulin therapy, you should continue it for at least what is the expected duration of action of the implicated CCB, and then start weaning slowly, otherwise there will be a rebound shock and hypotension. Also, you need to continue the glucose drip even for few hours even after stopping such high doses of insulin. The another specific antidote is calcium, because calcium is an antidote for calcium channel blockers, available in two forms, gluconate and chloride. Chloride needs a central line. The dose which we need to administer is high. It is around 20 ml of calcium chloride stat and per hour infusion, and the target is 1.5 to 2 times the upper limit of normal calcium. So you need to measure the ionized calcium every 15 to 20 minutes initially, and then after every hour later, till the time you continue the drip, because there have been reported cases, fatal cases due to hypercalcemia because of calcium therapy. So you can monitor the eye calcium from the ABG report, or you can monitor the ECG of the patient. Hypercalcemia, usually the first manifestation is shortened QT interval, so you can monitor the QT interval. Glucagon can be tried, but it is not recommended by the expert consensus recommendation published in CCM in 2017, and can be tried only as a rescue therapy by the AHA recommendation. Similar is the case for methylene blue. If the shock is vasodilatory, not cardiogenic, and patient is not responding to any other drug, you can try methylene blue, but be wary of the serotonin syndrome which this drug can cause if the patient is on SSRIs. The lipid rescue therapy or lipid sink therapy can be tried in very severe or peri-arrest cases. Generally, the intralipid produces a lipid sink-like effect. That is, it makes a intravascular compartment of lipids, and thus which sucks the drug into it and thus reduces the free drug concentration. However, certain reports have suggested that giving intralipid might increase the absorption of drug from the GI tract and thus increase the toxicity, and hence this is not recommended by the AHA guidelines. Last but not the least, the VA ECMO can be used if the cause of shock is mostly cardiogenic, that is there is severely low cardiac output and it is not mainly vasoplasic shock. However, the problem is with cost. So how do you explain the patient's relative that after using this very costly therapy and potentially having very serious side effects, will their patient be saved or not? So you can guess the survival by few factors, like if the lactate is more than 9, the survival has been shown to be low in case of using VA ECMO in toxic cases. Also, you can calculate the save score. If it is high, there will be 86% mortality if VA ECMO is used in poisoning cases. Last, dialysis has been tried and reported by several experts, especially in India. They use charcoal or resin hemoadsorption for calcium channel blockers. However, calcium channel blockers have a very high protein bonding and very large volume of distribution, and most of the guidelines don't recommend it for calcium channel poisoning. Coming to the summary of calcium channel blocker poisoning, generally the first line treatment are fluids, vasopressor and HIET therapy. Supportive therapies also include calcium, atropine, pacing and maybe methylene blue. The therapies like dialysis, glucagon and intralipid therapy are not recommended. Coming to beta blocker overdose, as we are running short of time, I will cover this in 1 to 2 minutes. Beta blocker overdose is more common than calcium channel overdose in India, as reported by some of the epidemiological studies, and mortality is around the same. Beta blockers generally act on the beta receptors on the heart and thus cause hypotension, bradycardia. Hypotension and bradycardia and shock. However, some beta blockers also act on the sodium channels, leading to QRS widening and arrhythmias. Sotalol can prolong the repolarization and cause torsades pointes, and also some of the lipophilic beta blockers like propranolol can cross the blood-brain barrier and cause CNS effects. So commonly the lipophilic beta blockers are propranolol, which also cause CNS effects, and atenolol is a hydrophilic beta blocker and generally has less CNS effects. So coming to comparison between management of CCBs and beta blockers, so generally the management is similar. However, calcium salts are not so much preferred in beta blocker poisoning. Glucagon is a preferred first line antidote in BB poisoning, but not in CCBs, as we have seen. High dose insulin therapy is also is also effective in BB, but not as much as in CCB. Lipid emulsions can be tried in lipid soluble drugs like propranolol, and dialysis can be tried in water soluble drugs like atenolol. Coming to cardiac glycoside poisoning, the cardiac glycosides are poisoning can either be therapeutic, that is because of digoxin, or it can be plant based. There are many plants which contain cardiac glycosides which are very commonly available in India, and these are the cause of cardiac glycoside poisoning, much more common than the therapeutic digoxin poisoning. So these are mostly reported from South India and generally taken with suicidal intent. The most common plant is yellow oleander, which is very commonly found in South India. The other plant is the suicide tree or cerebraodolum, which is also a very common cause of suicides in Kerala. Another common plant is mudar, also known as Calotropis procera. Therapeutic digoxin poisoning generally occurs in elderly, or if the patient develops renal impairment, and this is a chronic poisoning, not a overdose. It can also the therapeutic digoxin poisoning can be acute ingestions which are generally suicidal or sometimes accidental, but most common is the chronic incidental poisoning, which develops in elderly patients who are on digoxin, and now they develop some kind of renal impairment or drug interactions, and they'll end up in digoxin toxicity. uh, Mechanism of action of digoxin is that it acts on the sodium potassium co-transporter on the cardiac myocytes, and it it decreases the exit of sodium from the cells and thus increases the contractility. Most common manifestations and most severe manifestations are cardiac, and digoxin can cause almost any arrhythmias which are known, except for the one which it is used for treatment, which is the atrial fibrillation with fast ventricular rate. One of the characteristic arrhythmias which is seen with digoxin is bidirectional ventricular tachycardia, which is generally very rare in any other condition, and if you see this tachycardia, you must consider digoxin poisoning. Digoxin effect, which is ST depressions seen on very typical ST depression seen on ECG, are not a manifestation of toxicity, but it can be seen with digoxin in therapeutic ranges. The other common manifestations are gastrointestinal, like vomiting and diarrhea, and visual disturbances. One very characteristic but not pathognomic disturbance is the yellow vision. People see everything yellow. Serum digoxin concentration is very commonly available in many hospitals. The heart failure target range is 0.5 to 0.8, and significant toxicity is generally when the report comes above 8 to 10 nanogram per ml in acute toxicity. Generally, it should be measured only after 4 to 6 hours of acute ingestion. Otherwise, the drug will not be distributed into the tissues, and you will get falsely high and elevated levels. Also, serum level is generally do not always correlate with toxicity. So for diagnosis of a case of digoxin poisoning or toxicity, you must not entirely rely on serum levels, but there should be symptoms. The level could be very high, but if there are no symptoms, it is not digoxin toxicity. Hence, the digoxin toxicity is a clinical diagnosis, and if you find a potassium more than 5.5, one study has reported that it would be 100% fatality if the specific antidote, which is the Digoxin Fab fragments, are not available. So digoxin has a very large volume of distribution and is primarily renally excreted, and hence it is not effectively removed by dialysis. Also, very commonly co-administered antiarrhythmics like verapamil, diltiazem, and amiodarone can increase its level. The supportive management which can be tried are fluids, atropine, temporary pacing, and activated charcoal. And you must do the electrolyte correction like hypokalemia and hypomagnesemia. However, if hyperkalemia is present, which is generally because of the digoxin overdose, it should not be immediately corrected by the traditional measures, and especially should not be corrected by giving calcium because it can increase the toxicity of digoxin. Besides, if you give a specific antidote, that is the Fab fragments, the potassium will come down. So Digoxin-specific Fab fragments, which is available as in injectable form by the name of Digibind or Digifab, are very effective and the drug of choice for digoxin poisoning. These can also be used in plant-based cardiac glycoside overdose. As you can see, after giving Digifab, the digoxin level immediately come to normal within 30 minutes of administration. So the Fab fragments should be given in patients who have life-threatening arrhythmias, severe bradycardia, and hemodynamic instability, or if they have potassium more than 5 to 5.5. Empirically, for giving in a patient when you can't test the levels who are unstable, you must give 5 to 10 vials stat and repeat it after 30 minutes. If the patient is stable or the symptoms are mild, you can give 2 vials and then repeat with another 2 vials. The dose of Fab fragments can also be calculated based on the concentration, that is the serum levels of digoxin, and or it can be estimated if the amount of drug ingested in acute poisoning is known. For example, a single vial of Digifab contains 40 milligram Digifab, and a single vial neutralizes around 0.5 milligram of digoxin. So if 2.5 milligram is ingested, you have to give 5 vials. However, again, the problem with digoxin toxicity is the availability and cost. One of the case reports and news reports from Delhi NCR reported that the cost when they tried to procure Digifab was around 1 lakh per vial, and if you need to give 20 vials, the total cost of therapy would be 20 lakh rupees. So what they did were, in most of the case reports, they tried other measures, and some also tried resin hemoadsorption, and they were successful in treating digoxin toxicity with this. So any questions you can write in comments. Thank you.